Thank you so much. And now let's move on to today's clinical speaker. Dr. Danielle Brown is a graduate of USC, and she was in private practice in Los Angeles till early this year when we were fortunate enough to get her to join our clinical team here at Glidewell. She was selected for the Top 40 Under 40 Award from the National Dental Association in 2023, and she completed the Guiding Leaders program that same year. Now, she was here back in October and she talked about veneer preparations from full prep to no prep. And she's going to continue that discussion today, talking about veneer provisionalization as well as bonding techniques. Dr. Brown, it's all yours. Take it away.
Thank you so much, Dr. Park. So I do kind of want to start by saying I have a bit of a cold, so I do apologize if I don't sound great. Um, okay, so we
Sound
are
amazing.
going, I'm so sorry.
You sound amazing. You're good.
Oh, thanks. So today we're going to talk about perfecting temporization and bonding protocols for veneers. So our objectives for today, we want to understand the importance of temporization in veneer workflows. We're going to master techniques. So we're going to talk about using biotemps from the lab, chairside biotemps or acrylic. We're going to discuss detailed bonding protocols for specific materials. And then lastly, we're just going to talk about common challenges that we see with both temporization and bonding and how we can have better outcomes. So when I first started in private practice, I worked for a doctor who was very involved in cosmetic dentistry. And at the time, I really, really wanted to kind of do some cosmetics and do some veneer cases. And I was kind of bugging him for a while to kind of give me some cases. And eventually he did. And I was super, super excited. I had a veneer case 6 through 11, and I spent the first like 2 weeks before the case really going over everything that I needed for the preparation. So I had my textbooks and I was going over notes from dental school. I was watching YouTube videos. I came in and I was the most prepared I have ever been. And I walk in and my office manager says, "Hey, good morning. Really quickly, the doctor added a case yesterday at the end of the day. He has 2 root canals and 2 crowns, so he's going to take the lead assistant." And my heart sank for a moment because I was like, I was expecting her. Whenever I had kind of new procedures, he was nice enough to let me use the lead assistant. So I kind of, it shook me for a little bit. But I said, okay, this is a change, but not too detrimental. I'll be okay. Until the second assistant came to me and she said, "Well, what's your plan for temporization?" And my heart sank. I had no plan for temporization. I had spent all of my time figuring out how to prepare the teeth, but I had no clue what to do on the second half of the appointment. And in that moment, I realized I also had no clue what I was going to do at the delivery appointment. And there was just this fear. Luckily, the patient wasn't until the afternoon, so I had a little time to kind of try to look some stuff on YouTube, pick my brain a little bit, but I was still pretty nervous about what I was going to do. I got even luckier though, and we had a power outage, and we ended up so behind schedule that we had to reschedule the patient to another day. And it worked out that the other day, the day the patient was rescheduled, I got the lead assistant. But that power outage really taught me, or that whole experience taught me two things. One, what do I do if there is a power outage while I'm mid treatment? I had no clue what to do. But also how important it is to know what you're going to do and not rely so heavily on my assistance. And so from that moment, I went and I did try to do some research on how I was going to temporize. And I found that it was really hard to even find information on that. So that's one of the reasons that kind of motivated me to put this class together because even now it's so easy to learn so much about prep, but not so much about temporization and bonding. So today we're going to kind of dive into all of that. So we're going to start by talking about the role of temporization and why do we temporize. So when I was in private practice, again, the majority of my dentistry was really done in the posterior. So when I was doing any dentistry that wasn't same day, temporization really wasn't that important. I was just kind of thinking, I'm going to make a copy of the tooth with an alginate. I'm going to use bisacryl, make sure there's contacts, occlusion. I don't really care too much about aesthetics. Aesthetics will be fine, but I really wasn't super stressed about what aesthetics would be like. And neither really was the patient. The patient just really at that point wanted to get out. It was a back tooth. It just needed to hold the space, prevent sensitivity, and not trap food. But with anterior teeth and with veneers in particular, the needs are pretty different. Yes, we want to hold the space, but there's a bit more involved in what we're looking for with temporaries and veneers.
Dr.
So,
Brown?
similar to single unit posteriors, really the main purpose is still the same. We want to protect the prepared tooth. We want to shield the tooth surface. Veneer preps involve removing ideally a thin layer of enamel, but sometimes, depending upon what the tooth looks like, we have to prepare into dentin. And that can lead to a little more sensitivity to temperature and a little more discomfort for the patient. So, the temporary really protects the exposed dentin and the cut enamel and helps to reduce sensitivity. It will also
Okay.
reduce any damage by acting as a physical barrier. So, we're not going to get any wear, fracture, or contamination while the patient is waiting for their final restoration, and it aids in thermal protection. So it's going to insulate exposed dentin from thermal changes and reduce sensitivity.
Dr. Brown,
Yes.
we're not seeing your slides.
Oh, I haven't changed anything. Huh. Okay, let me try again.
Yeah,
Have you
we'll have
seen
you
none of them?
no, we'll have you reshare.
Okay.
Well, your story was so good, so we're
Okay.
like
I know it was very
Okay.
compelling without
yeah, it
slides.
was
Thanks.
and then if you can just change the presentation view, please.
Yes.
Thank you.
Thank you. How about now? Can we see slides?
Yes, there we go. We
Yes.
have
Okay.
yes.
Perfect. So the role of should I start out? No, I'm just playing.
No, no.
Um, so protecting the prepared tooth is our first goal. So the second role of temporaries are maintaining function and aesthetics. So really, we want to make sure that we're maintaining the appearance for the patient. The patient gets an immediate aesthetic solution, so they're able to maintain their smile while they're in that interim phase, which is really, really important with veneer cases because we want the patient to be able to go out and function in society. But it also maintains function. The patient is able to eat, speak, and smile comfortably while they're waiting for their final restoration. And the third role of temporization in veneers is it really is to help test the fit in the design. It gives us a trial run for the final veneer. So they really do serve for the patient as a preview of the final result. Generally speaking, when I'm placing veneers or doing veneers for patients, they're really not a same day thing. The patient comes, we do a wax up. I use a wax up to fabricate a mock up. I'll use that wax up to make their temporary. So the patient is able to really trial run what their final restoration is going to be. So the patient and myself can evaluate the shape, the size, the contour, how the occlusion is. Are they able to speak? How's their phonetics? They're able to really, really try out exactly what their final restorations will be for the week to 2 weeks that they're in the temporaries. And generally speaking, I tend to do cases that go from about 4 through 10. So because they're larger cases, I'll see the patient back in about a week. That's given them enough time to talk, go to work, eat, do everything that they need to do. And they can let me know if there's any changes that I need to make, if there's some sort of contour they want me to change. And if I do that, I'm able to just take a quick scan, send it to the lab, and have the final restorations fabricated based off that. So it really does help to test out the design before we go ahead and deliver the final restoration. And so these are our three main roles: protecting the prepared tooth, maintaining function and aesthetic, and testing fit and design. But that's really, really important and why I don't like to refer to veneer temporaries, especially as temporaries. I like to refer to them as provisionals. I think by just shifting our dialogue and using the word provisional for the patient, it gives them a different level of importance and respect for what's happening. They're not necessarily viewing their trial smile as just something to hold the place. They really do think about it as something that they need to focus on, that they need to work with, and kind of get used to. And it's a provisional, it's a tryout. It opens up better communication, and we're able to deliver a final result that they're very, very happy with. So material selection is another area where the thought process is slightly different when we're considering veneer provisionalization compared to any sort of full coverage posterior restoration. So again, when I was doing more posterior work, I relied heavily on an alginate impression that I took before we started treatment and then bisacryl. Every so often, I would order a lab fabricated temporary. Um, but for the most part, even when I was doing veneer cases, I was using putty or PVS and giving the patient back what they came in with. Um, and I didn't really put too much thought into material. But as I've shifted and started doing much more cosmetic cases and larger cases, I do put a little bit more thought into the material that I'm choosing. So the three options that I typically will go for the most are still relying on Old Faithful, so PVS and acrylic. I'll use a lab fabricated temporary or a chairside milled temporary. So with our acrylic temporaries, these are typically done. Again, they're chair side. So I will start by taking a PVS impression of how the patient either came in, if it's a same day treatment due to trauma or something, or I'll do a PVS impression based on their wax up and what I want their final restoration to be. And then I will use acrylic to reline and create a temporary for the patient. So we start with a high quality PVS or putty impression. And then once I've captured my impression and I verify that I have adequate cervical margins and that the incisal and occlusal edges are properly captured, my first thing that I want to do is I'll trim my matrix. So I like to scallop the edges of the matrix like you can see in these photos here. And I like to extend it slightly beyond the cervical margin, so about a millimeter and a half. That way, when I seat the matrix, I'll get a slight overflow of material, and I use that material to judge if my material is set, but also it makes it a little easier to kind of clean it off. Um, so I like to go ahead and really take that time to make sure that I'm scalloping the edges of my impression before I seat it. The other thing I do before I seat my impression is I mark the midline. So I'll either use a marker or a blade to kind of cut a divot in this area, but it really helps to ensure that I can seat the putty correctly on the first attempt. We've all had that situation where you placed your acrylic and you're trying to seat the matrix and it's off by one tooth and you're kind of hoping that you have enough material that you can shift it and it's okay. And you just don't want to have to deal with that or have to redo it. So I always, always, always take the time to mark the midline. And I find that over time, this has really made seating of my matrices much, much easier. So after I have my matrix ready to go, I will take my acrylic. I'll bleed a little acrylic out. And then I like to start on the most posterior tooth that I will be preparing. And I like to just slowly dispense material out on each individual tooth. I start at the incisal edge, work my way up to the cervical, and I go tooth by tooth without actually lifting the tip out of the material. If you lift the tip out of the material, you run the risk of introducing voids and bubbles. So I really like to try to keep my tip in the material as I'm moving. One thing that we have to consider when we are using bisacryl is you have to consider the chemical properties of the material. And we've got to remember that bisacryl cures with an exothermic reaction. So it's going to give off heat as the material cures. So it's important to not leave the putty matrix fully seated throughout the entire polymerization process. So I'll seat my matrix. And then, like I said, I have that nice amount of overflow. I'll use a perio probe or an explorer to touch that material, see once it's starting to feel tacky. If it is starting to feel tacky, I will remove it slightly and then reseat it just so that it's not on the tooth, especially in areas where I've exposed dentin, as it's going through that reaction because it does get quite hot. So our second option would be a lab fabricated temp. And this is a biotemp. So any biotemp I'm sure we've all used where you communicate with the lab and they send you back temporaries. These can be milled or printed. They can use your virtual prep or an actual prep. Generally speaking, if you are using a wax up or whenever I'm doing any of these cases, I will just rely on a virtual prep. So the lab will take my existing patient's presentation, they will take the wax up, and then they will just make a shell. So we all made shell provisionals in dental school. It will give us a really, really thin material so that we have room to reline. And these provisionals will come either in a splinted number of units, so you can get it anywhere from the entire arch or broken up into segments or individual temporaries. And so again, we can see splinted units or individual temporaries, and they all come with a seating jig, this clear matrix to help you seat the jig, to seat the provisionals when you were going to go ahead and deliver them. So here we have a case where I had prepared again 4 through 13, and I had shell provisionals, shell biotemps made. You can see how thin they are, and they're made in segments. I personally prefer to have them made in segments because I just find that I get better retention. You can see using the seating jig makes it infinitely easier to seat all of your restorations so you can reline them all at once without having to kind of go back and forth. So in order to reline, I like to start, and I don't show this, but I like to start by micro etching, and then I will place a little bond, and then I just use my temp material. So bisacryl, Luxatemp. Um, right now I'm showing that you can do this as a single splinted unit without the seating jig. So we've gone ahead and seated one set, or it's just as easy to do the same thing using the jig, and we're able to seat multiple units. I'm not sure why that jumped there. I do apologize. But we're going to go ahead and seat all of the units at one time. The process of how we're going to reline biotemps, you're going to start by micro etching the intaglio. I use a Danville micro etcher, aluminum oxide with D-micron sand. I then place bond on the intaglio of the restoration. I air thin, but I do not light cure at this point. I will then place it back in the jig if I'm going to use the jig. If not, I will place the acrylic material into the biotemp, seat it and reline, and then I will light cure. I then remove the entire unit and cement with my usual cement of choice. And then our third option is a chairside milled biotemp or biotemp now. These I typically only do if I am doing 1 or 2 units because you do have to take the time after you have prepared the teeth, you have to scan the arch, and then you have to mill them out chairside. Using a biotemp, the benefit, biotemp now, excuse me, is your units typically mill in about 10 to 15 minutes, so it's not a long wait, but I prefer at this point, and the patient tends to prefer at this point, to get out as soon as possible. So I will typically only use a chairside milled veneer temp or biotemp now if the patients come in and it's been an emergency and we're doing it, or if it's just a single unit. After we've created our temps, how our provisionals, however we choose to use them, we have to go ahead and adjust them because they're never perfect. So I like to start by doing my adjustment with a fine grit diamond. So I like to use the 863010. It is a friction grip, fine grip flame diamond, and I really like to do the majority of my adjusting with this. I find this burr, or excuse me, I like to do my finer adjusting with this. So I like to use this burr around the margins or in an anterior case, I like to do it to open up the embrasures just a little bit more. The majority of my gross adjusting, so any area where I have more material than I would like, I will use a coarse grit diamond, so an 865025, to just remove any sort of gross material that needs to be removed. I then will also use that friction grip fine diamond in a pointed cone to really just further open up any embrasures and do any really, really fine adjustment that needs to be done. Before I cement, I like to use the Robinson brush to do sort of a preliminary polish just to get a nice shine. And then after I've cemented and it's in place for the patient, I like to use Sparkle Diamond polishing paste and a polishing brush to really, really shine up the provisional before I dismiss the patient. Because it's very important that the patient gets to see their smile as it would be when they leave, so that they don't have a dull matte restoration, which can really kind of impact how they view the veneer. After we've adjusted, we move on to delivery. The biggest key with delivery that I know is you want to make sure that you are using a cement that does not have eugenol. Eugenol can interfere with binding of your permanent restoration. It can inhibit the polymerization of your resin-based cement. So I always opt for a cement that does not have eugenol. A lot of times that will be listed. The other reason I tend to stay away from that is eugenol can be cytotoxic to pulp tissues in high concentrations for a prolonged period of time. So especially if I've prepared into dentin, I will absolutely stay away from a temporary cement that has eugenol. So I typically will go with Temp Bond Clear by Kerr or Bifix Temp by Voco. And these are both clear cements. For bonding of the provisional, I like to utilize etch and bond in order to give myself a little bit more strength. In this case, I had a patient who had two veneers on 8 and 9, but number 8 ended up being root canal treated. So I did a full coverage crown on that, but still a veneer on 9. I like to place a dot of etch near the incisal edge, but not at the incisal edge. And then I will place just a small amount of bond in that area before I bond and deliver my provisionals. The reason why I always place it in the same area is if I do have issues when it comes time to seating the final restoration, because I feel like there's something holding it up, I know exactly where to look. It will always be that same area where the bond is. And I like to stay away from the incisal edge and away from the cervical margin because those are very, very important areas. So I place it near the incisal edge, one small dot, same size on every tooth. When I place my cement, I do like to place a lot of cement so that I do get that cement squish where it pops out, that you can see it's coming out of the restoration. I will then light cure and then use just a sickle scaler to remove any excess material. I do also, um, sometimes I will tack cure, but generally speaking, in cases like this where they are splinted, I will go ahead and just do a full cure. I then make sure that the lingual surface is clean, and then I will floss, and I also will polish these restorations as well. There are several challenges that we tend to see with provisionals that I do want to go over, really the top three that I have had over the years, and how we can overcome them. So the first challenge that we tend to see is sensitivity. The number one cause of sensitivity that patients have is the veneer is not properly relined. So I do recommend after you have relined your provisional, taking it off and really evaluating the margins and making sure that as you're trimming away the excess, you are not trimming away the margin. I try it in multiple times and check multiple times before I finally go ahead and cement because I want to ensure that the margins are sealed. If the margins are sealed, or once the margins are sealed, I do still like to protect from sensitivity by using a desensitizer. So I will use something like G5, Bluma, or Microprime to really help with desensitization over the time that the patient is in the provisionals. So I do like to apply a small amount, and I use a micro brush to scrub it in on each tooth for 30 to 60 seconds. The specifically Bluma states that you should do it in 2 coats. So generally speaking, I will do that in 2 coats. I find that we all have our things where we kind of cut corners. Maybe we etch a little shorter time than we should, or something else that we all kind of cut corners. But with desensitization, I really do take the time and apply 2 coats, 30 to 60 seconds on each tooth. It does kind of extend the appointment out a little longer, but I find it to be very helpful. After I've applied the 2 coats, I will then use a suction or a thin stream of air to just lightly spray it on the tooth until I no longer see any movement of the material. I am not going to go ahead and sort of really aggressively dry it because you don't want to desiccate the tooth. You want to ensure that you're not going to cause the collagen fibers to collapse. So you're just going to lightly dry it until the surface is no longer shiny or the material is no longer moving. I use a desensitizer for all cases. So whether it is a full coverage, inlay, onlay veneer, and whether the tooth is vital or non-vital. So we're using it for the desensitization properties in a vital tooth. But in a non-vital tooth, I use it because studies have shown that the use of Bluma helps to or Bluma or G5 or Microprime helps to increase bond strength. So I will always use a desensitizer, whether it is a vital or non-vital tooth. The second challenge that we tend to see with veneers is it's really hard sometimes to get them to stay on. The way I've gotten around that is I tend to stay away from single unit veneer provisionals. I splint my restorations. So in some cases, if I am going to go ahead and use my PVS matrix, I will do an entire roundhouse provisional. But if I'm sending out for a biotemp, I'll have them splinted in at least 3 units. That way, I'm able to utilize the undercuts that are kind of present just by nature of preparing 2 teeth next to each other. And I can get my resin to kind of lock in there and it will hold on to the temporaries a little better. If you're going to do a posterior tooth, you have the option with a biotemp of going ahead and having a wire reinforcement. You can't really do that in the anterior. So I do rely on splinted provisionals for that. And then again, utilizing bond to help it stay as well. And then the last challenge that we tend to see is patient management. A lot of times we get patients who you give them their provisionals, they go out, they're super happy about their smile, and they just want to go out and function and live life regularly. And it's very important to explain to the patient that there are things that we have to kind of do in order to ensure that A, these provisionals stay on, but B, that everything is healthy when you return for delivery. So I explained to the patient, number one, it's super important that they are going ahead and continuing with their regular hygiene, specifically brushing. They are brushing right along the gum line and those around these provisionals so that they have healthy tissue. The last thing they want to do is show up for delivery and everything is bloody and I can't deliver that day. So I really take the time to stress that to the patient. I also explain to the patient that because I'm utilizing splinted provisionals, they will not be able to really floss that area. So I stress to them how important it is to go ahead and make sure that they are brushing, rinsing, utilizing a water pick, because they will not be able to floss easily in that area. And then the last thing I do is I let them know, again, these are provisional restorations. This is not the final. we're going to have to make some modifications to your day to day. So I let them know we're not biting into carrots and apples and corn on the cob. We're cutting all of these things simply because we don't want to increase the risk of fracturing this restoration or having it pop off. So it's very, very important before you dismiss the patient after they've seen and approved their provisionals to really have this in-depth discussion with them so that they know what to expect when they return for the delivery appointment. So after the patient has been provisionalized, we're going to move on to delivery. The way I approach my delivery appointments is I let the patient know that you are coming for a try in. I never tell the patient it's a delivery appointment because it simply might not be. I let them know we're going to try in all the restorations. If they are happy and if I am happy, then we'll see about going ahead and delivering them. I like to just kind of set the expectation so that the patient knows that it might not just be a simple in and out in 1 hour. I also let the patient know when you have a crown delivery, they typically expect, again, that in and out in an hour. That's what I like to see when I'm delivering a single unit crown, in and out. But I let them know with veneer deliveries, these are much longer appointments. There's a little bit more adjustment, a little more polishing. I just like to, again, set the expectation. You will not be in and out. This is a slightly longer visit. The first thing we like to do is adjust our restoration. So, three tips that I've really picked up over time when we go from provisionalization to delivery. The first one is when I adjust, I like to do the majority of my adjusting with a pink wheel. I find that because it has that diamond impregnation, it really helps to both adjust and polish at the same time. So, I will do the vast majority of my adjustment with this pink wheel on a slow speed handpiece. The second thing that I like to do when I am adjusting restorations, I don't know if any of you guys are using occlude spray. I like occlude spray. A tip that I picked up from a mentor is to actually spray it on the tooth and not the veneer. If you spray it on the veneer, every veneer has small micro cracks, just the nature of a restoration being fabricated. There will be some cracks or some porosities. This spray is bright color, usually bright blue, sometimes bright green or red. If you spray it on the restoration, you might have a much more difficult time removing that color from out of those cracks and microporosities. So whenever I go ahead and if I have to use a spray, I will spray it on the tooth because you can then polish it off much easier than trying to remove it from the restoration. And my third tip for trying in is to utilize a try-in paste, but utilize a try-in paste that has color to it. So a lot of cements, specifically for the anterior, will come in different shades, different warmths, different hues, and they will come with a try-in paste that corresponds. So, and you have cases where you have maybe one tooth that has been endo treated and you're trying to match it to the adjacent tooth, or one tooth that's been traumatized, so it's a little darker than the other. The stump shade is darker. You can get away with utilizing try-in pastes that have different shades and different warmths to make sure that your restorations match and give the look that you're going for. So these are really my three top tips for what I do during my adjustment in try-in paste. So after we've gone ahead and gotten adjusted and tried in and we're ready to go, it's time to bond. So there's a few things I want to go over when we're discussing bonding. So bonding is the process of adhering the restorative material, so your veneer or your crown, to the tooth surface. And the success of dental bonding really, really relies on your precise preparation and the chemical interactions of the materials that you use. So it's very, very important that you are aware of the material that you're using both as a restoration and as a bond. So there are steps that we're going to follow both on the tooth and on the restoration side. We're going to start with the tooth first. So the first step with the tooth is to etch. So we start by utilizing a 30 to 40% phosphoric acid etch to create micro retentive little patterns and grooves on the tooth surface so that we can get proper adhesion of the material. I utilize a total etch technique, so I etch the entire surface of the prepared tooth. Um, you start by etching the enamel. When you are etching the enamel, your ultimate goal is to remove the outermost mineralized layer, so the hydroxyapatite crystals, and you're creating microporosities to sort of increase the surface area for your bond. Total etch means we're going to etch enamel and dentin. By etching the dentin, we're removing that smear layer that was created during preparation or while the patient was temporized. It also helps to open up the dental tubules and expose that inner collagen network so that we're able to get proper penetration of our adhesive resin into that demineralized surface. So we're going to etch the enamel and the dentin using a 30 to 40% phosphoric acid etch. It's very, very important that you follow the instructions when you are etching because there are consequences for both under and over etching. If you under etch, you really just run the risk of insufficient removal of that outer layer on the enamel. So you're going to reduce retention and you're going to have a weak bond. And the same thing can happen with the dentin. You'll have an incomplete smear layer removal and you really won't enable that adhesive resin to penetrate into the collagen. So you're going to have a poor hybrid layer and a poor bond. So under etching is one problem. Over etching is also a problem. If you over etch the enamel, you can weaken the enamel and it can lead to, again, also poor bonding, but increased sensitivity. And that really is your biggest risk, increased sensitivity. So I recommend, etching appropriately, not over etching or under etching. After we've etched, we are going to treat the tooth with both a primer and an adhesive. The primers, they're chemical agents that prepare the surface of the enamel and dentin for bonding. So the primer, the primary goal of that is to condition the surface. It increases the wettability and it enables the adhesive to really flow into the tooth surface. It serves as really a bridge. So it's going to bridge the gap between the dentin, which is hydrophilic, and then the resin, which is hydrophobic, and it forms the bridge between the two of them so they're able to link with each other. So you're going to go ahead and apply your primer. After you apply your primer, you're going to apply your adhesive, and the adhesive infiltrates that primer surface. The primer really kind of creates like a slide so that the adhesive can really get in and fill in any voids that you created when you etched. And it forms these kind of resin tags so that so that the adhesive is able to bond to the tooth. Once you go ahead and light cure, you're polymerizing that adhesive, and it really helps. That is what creates that bond. As far as using a primer and adhesive, these are some of the ones that I am most common with, most familiar with, excuse me. So Futurabond, OptiBond, and Single Bond Universal by 3M are really the ones that I go to the most. I do not really use a separate system. I typically will use a primer and adhesive and in one, but I have done both and I am comfortable with both. So after we've treated the tooth, we're going to move on to treating the material. And how you treat the material, again, depends on the type of material that you are using. So the first step with the material is also to etch and create microporosities. And the way we do that depends on the material that you're using. So if you are using a material that is glass based, so your glass ceramics, lithium silicate, lithium disilicate, so here that would be our obsidian from the lab, obsidian milling blocks or Emax, or if you were using feldspathic porcelain, you are going to create those microporosities by using a hydrofluoric acid. So you're going to use 9% hydrofluoric acid, phosphoric acid for the tooth, hydrofluoric acid for the restoration. You use this on ceramic material to create these micro-retentive surfaces because it will dissolve that glassy matrix that's present in the ceramic, and it's going to expose that crystal structure so that you can get good micromechanical bonding. It's very, very important that you do not over etch with this. This is a 10-second etch. If you over etch, you can weaken the ceramic. So just like with the tooth surface, it's very important that you follow the instructions specifically. So those are for our glass ceramics. For zirconia, it's a different beast. So when we talk about zirconia here at Glidewell, Bruxer is our zirconia of choice. So we're talking Bruxer Full Strength, Bruxer Aesthetic, Bruxer Now, or Bruxer Aesthetic Now, which are our chairside milled versions of Bruxer. You cannot rely on hydrofluoric acid. You have to rely on micromechanical etching. If you order a restoration from the lab, it will come to you already etched. So they will already have etched it. You do not have to. If you are milling chairside or if you're ordering from another lab, you might have to go ahead and micro etch your restorations. So again, 30 to 50 micron alumina oxide to etch the entire intaglio of the restoration because hydrofluoric acid cannot penetrate um, into the surface of zirconia. What I like to do in order to ensure that I am etching the entire surface with a micro etcher, I will have my assistant take the restoration. They'll use a Sharpie and really color the entire intaglio surface of the restoration. And then they'll go ahead and utilize the micro etcher to remove all of that material. That way I can see that they've gone in and they have etched the entire surface of the restoration. After you have etched, you will then go ahead, more than likely try in your restoration, get yourself where you're adjusted. properly, you need to decontaminate. And in order to, in by decontaminate, I mean we need to go ahead and remove any sort of salivary phosphates or saliva, blood from the surface of the restoration. The number one reason, again, is to remove saliva and blood contamination because as you're trying them on, it becomes contaminated, and that contamination can lead to issues with bonding. If you are delivering, especially zirconia, it's very important to remove any sort of salivary phosphates. So, decontamination does that as well. And you want to remove any just residue that might be on the restoration. The ways I do this, you can use sodium hypochlorite, Ivoclean, or you can place the restoration in the ultrasonic. I typically rely on Ivoclean to decontaminate all of my restorations, regardless of type. With the Ivoclean, you're just going to go ahead and scrub it into the intaglio of the restoration. I typically will use a micro brush to fully scrub, let it sit for 60 seconds, and then rinse in airfin. I will show you a video of that in just a little bit. And then after we've decontaminated, you're going to go ahead and treat the surface of the restoration. And I know how confusing this can be. We talk about silane or zirconia primers. And in my mind, the question was always, what is what and when do I use what? So we're going to take a moment and break this down by material type. So again, if you're using your glass ceramics or your feldspathic porcelain, they have a glass base, they have a silica base, so you can utilize silane. So silane is a bifunctional molecule that again creates a bridge. Whenever we think of primers, it's just creating a bridge. So one end of the material will act with the silica in the restoration, and the other end of silane bonds with the methacrylate group in the resin cement. So it's just forming a bridge. The easiest way to think of this is if it's glass, there is silica, silane, SiL, SiL. That's how I think about it. However, if you are using zirconia, it is an entirely different process. You need to utilize a primer that has MDP. MDP will do the same thing. It goes ahead and it creates that bond or that bridge between the resin cement and the restoration, but it needs to be MDP. So this is your Z prime. Um, it has to contain MDP. I recently had a friend who called me because she had delivered 10 veneers in the anterior, and within 2 days they started popping off. And she had the first one popped off, she had the patient return, she rebonded it, and then the second one popped off. So then she called me with questions. And so I asked her, what was your process? What did you do? She's like, I etched and I microabraded the tooth or the restoration, and then I did bond and then I primed. And I said, what did you prime with? She goes, I silanated. And I was like, well, there's zirconia, so you cannot use silane. You have to make sure that you are using an MDP containing primer. My recommendation to her, like my recommendation to all of you, is to purchase a primer that contains both. So Scotch Bond Universal, Monobond Plus, and Clearfield Ceramic Primer Plus all contain silane and MDP. I know how easy it is to kind of just get used to what your assistant hands you, especially if you've been working with the same assistant for years. You kind of just get a groove going. This removes any and all doubt. I don't have to check to make sure it's the right primer. My assistant doesn't have to really double check to make sure it's the right primer because it is always the right primer. These three primers contain MDP and silane. So any veneers, really any anterior work, whether it's porcelain, glass ceramic, or zirconia, you can deliver using these three primers. I highly, highly recommend purchasing these. And then our last step is bonding. So we're going to go ahead and break down what I look for in a cement when I am going to start to bond anterior restoration, specifically veneers. The first thing you want to do is make sure that you are choosing the right cement. And when I say that, you want to ensure that you're using a cement that is made for the anterior. Cements that are made for the anterior um, really have aesthetic considerations kind of built into their formulation. So they're highly translucent. They have a finer particle size, so you get a more smooth texture, and the handling is a little different with these. I find that some of these anterior cements are a little tackier, a little thicker, which are a little easier to work with. And I'm going to show you a list of these in a moment. The second thing I'm looking for is a cement that comes in multiple shades, and that ties in with my next line, is that it comes with a try-in paste that corresponds to the multiple shades. Again, a lot of times we have teeth that maybe adjacent teeth have different stump shades. So I like to try in with a different try-in paste and then utilize potentially different cements on number 8 versus number 9, depending upon what the stump shades are. So it's very, very important they're using a cement that comes with multiple shades so that you can kind of get a true and uniform look amongst all of your restorations. And then lastly, what I look for in an anterior cement is that it is light cure and not dual cure. I have learned this lesson the hard way by using a dual cure cement to deliver 10 veneers, and it was a nightmare. That 90-second working time that you get is a lot quicker when you're trying to place 10 units at once. So that's one reason, the time. But the second reason you want to ensure that you have a light cure cement and not a dual cure is the initiators that are placed in a dual cure cement that allow it to cure on its own can kind of mess up the color stability over time. So you want to make sure that you're using a light cured cement so that the color stays stable throughout the entire life of the restoration. So these are what I'm looking for in a cement. Made for the anterior, multiple shades with corresponding paste, and it is a light cure, not a dual cure. So these are the 4 cements that I typically use the most. I use Variolink Aesthetic, LC, which means light cure, Panavia V5, Rely X Veneer, and then Kerr NX3 or Nexus 3. Of these 4, the 2 I typically will use the most would be the Variolink aesthetic because I do like the differing, shades that it comes in, the differing warmths, and then the Kerr NX3. I like to use this one because this is the one that I talked about that has a thicker consistency to it, so you can kind of really seat it and play with things a little bit more. You don't have to worry about it kind of slipping as you're placing them. So these are my 4 go-to, but those are my top 2 cements that I recommend. The next tip after we've chosen the proper cement is proper isolation. I am a huge fan of using an isolite and an obtrugate. So the first photo is an obtrugate. It helps to retract the lips and the cheek so that I have adequate visibility and I don't have to kind of fight with anything or cotton rolls. We've all had a scenario where you place a cotton roll and the cotton roll gets caught in the cement and now you're fishing it out. This really, really helps to fully retract everything. I get great visibility. Also, I recently started using isolites that are made specific for the anterior. For a while, for years, I was using regular posterior isolites and they were fine, but this new iteration is made for the anterior, so it's much easier to go ahead and place these veneers with this type of isolation. I personally utilize both at one time. It just makes life easier. It suctions, keep the patient open, and retracts the lips all at once. I don't have to think about anything. The third step is these wooden bite sticks. I am a huge fan of these bite sticks when I am attempting to deliver any veneer case. I will use 2 sticks per case. I will use the stick to press on both the facial and the incisal at the same time so that I'm ensuring that the restoration is seated exactly where I want it to be seated. I'm not dealing with kind of using my fingers and getting my glove sticky. These wooden sticks have been a godsend. I highly recommend them. And then the next step with that is I like to deliver my restorations in pairs. So I'm going to show a brief delivery in a moment. But when I say I deliver in pairs, again, I typically will do 4 through 13. So that's 10. I'll start with 8 and 9 first. I'll deliver those. And then I will move on to one side. So I will then do 6 and 7 and then 4 and 5. And then after that, move on to the corresponding on the contralateral. It's just much easier and it does take a little bit longer, but I find that my cleanup is a lot easier and I'm not really fighting with a lot of excess cement. So I do deliver all of my veneers in pairs. And then my last recommendation is utilizing the ability to tack cure. And how do I do this? I use a curing light that has a much smaller tip specifically for tack curing. So again, I'll show this in the video, but I will use my bite sticks. I will press on the facial, press on the incisal, and I will have my assistant come and she'll use this tip. It's about 2 millimeters at the tip of the curing light. Place it in the center of the tooth, and she will cure that one spot. What that does is it holds the veneer in place, but it hasn't cured everything. So I'm able to go ahead and I have time to clean up any excess cement that remains, but I'm not worrying about my veneer sort of shifting and moving during that process. So these are my tips when I'm delivering proper cement choice, proper isolation, wooden bite sticks, delivering in pairs, and then tack curing your restoration. So before we go, I do want to just go over one brief patient case. So this is my patient Mark. He presented with teeth 6 through 11 that he was very unhappy with. His premolars, he has a couple of implants and a couple of crowns, so he really wasn't interested in doing anything with those because I do like to include premolars. He was really just focusing on the true anteriors. He had some spacing initially, so he had some composite buildups placed, some recurrent decay on all of these, chipping of his teeth. So he was a perfect candidate for veneers. These were not going to be minimal prep veneers. These were going to be pretty extensively prepped in some areas, but that was our plan going forward. So again, because he had some existing restorations and some decay, these were prepped into dentin, and they do kind of wrap in some areas. But the linguals of these teeth were really healthy, so I didn't want to go full coverage crown on these. So we did what I've heard referred to as super veneers on these cases. So we've gone ahead. I got my restorations. They are Bruxer that I ordered from the lab. So because they came back from the lab, they were already etched. So all I'm doing is decontaminating. So this is again that Ivoclean. I like to place it in the well of in the intaglio of the restoration, and then I use a micro brush to polish it in there, kind of scrub it. I learned the hard way how important it is to place a paper towel in the base of the sink whenever I'm going over rinsing a restoration. So I did that. I go ahead and rinse. And then again, Mono Bond Plus. These are zirconia. It has MDP. But if I chose to do an obsidian, it also has silane. I then move on. I let that Monobond Plus sit in the tooth. I place them all on the back table while I move on to etching. I find using a paintbrush very helpful when I'm etching because I'm able to really apply it everywhere across the entire tooth without having to use a whole lot of etch. And again, a total etch technique. We're going to go ahead and rinse all of that off. And then after everything is rinsed, I will lightly air dry the tooth, but we're not going to, again, aggressively dry it because we don't want to desiccate the tooth and collapse the collagen fibers. I then, like I discussed, go in with Bluma to desensitize. Again, desensitization, but also helps to increase bond strength. One thing I do want to point out in this video, you can see when I'm using the micro brush, I have it bent. I've actually stopped doing that. I took a class recently where I learned that bending the micro brush, you're not able to get the adequate amount of force that you should have in order to get these materials to properly penetrate into the tooth surface. So I've shifted. If I do bend them, I will bend them, but I will hold it down at that tip. So that's one tip for all of you. Try not to bend your micro brush. So that was me applying the bond material, light cure. And now we're going to go ahead and see what I mean about delivering in pairs. So I start with number 8, number 9. I didn't show the bite stick. I will show it next. There we go. So we're going to utilize the bite stick, one incisal, one on the facial. And then I'm able to just take the time. After I've tack cured, I can go ahead and floss around these two teeth before I start delivering adjacent restoration so I'm not really fighting with the interproximal contact. And then I will move to the entire right side. So now 6 and 7, and then repeat the same process. I like to use a little, again, the bite sticks, a lot of cement, just so that I get a nice cement squish out. Um, so we will tack cure and then remove excess floss. You can see those bite sticks. You can see the veneers moving just slightly. It's very, very helpful. And then we're going to go ahead and floss all of the restorations or all of the contacts, making sure that we're removing any excess cement. Again, I like to utilize a sickle scaler so that I can remove any excess. So similar to when I do temporaries. Multiple flossing, I always explain to the patient afterwards, their gums will be a little sore. They'll probably have some bleeding because we flossed a lot. And then again, final cure after we've removed all of the cement. That's the biggest reason why I tack cure because I can take the time to remove all of the cement without any adjusting or any moving of the restorations. And then I can do a final cure at the end. I'm going to go ahead and I like to floss and rinse, remove anything that's left. And then at this point, I will adjust occlusion. So earlier I talked briefly about adjustment, but I don't, that's just if I'm having issues with the interproximal and I can't quite seat the restoration. I do not check occlusion until after I've delivered. Two reasons. One, the patient tried the smile out. So they have come to me, I've seen them back after the preparation, so I know their bite is fine. So if there's any adjustments that I need to make, they are minor. And then I go ahead, once they're cemented, it's much easier to adjust just any high spots that you might have because there's always slight differences. And then because these are zirconia, I followed it up with our Bruxer polishing and adjusting kit. These are diamond impregnated cups that really, really help to give you a nice final shine. And then I will use my diamond polish and my polishing brush just to give the patient that great shine and luster before they see the final restoration. And here's my patient seeing it. And the wow is always my favorite part. And so here are his final restorations. These were Bruxer Radiant, which is our newest highly aesthetic Bruxer zirconia restoration. We delivered 6 through 11, and here's his final smile. And that is all I have for you today. Thank you very much, and have a happy holidays.
Well, Dr. Brown, thank you so much. That was a lot of
Thank
great
you.
information. I've got a ton of questions. We're already a little over our time, but I think first, let me say that this recording, like all of our webinars, will be posted on our website. So probably by next week, you'll be able to go back, retrieve this, and if you missed any of the details, you can go back. But I did have a whole lot of questions
Okay.
about the beginning portion where you showed how to use the biotemps. Can you
Mhm.
just kind of go quickly through the steps? Specifically, did you use any kind of a bonding liquid on the intaglio of the biotemps?
Yes. So the first step is you're going to go ahead and micro etch. So I'll air a braid, and then I will place bond, that regular adhesive bond that you're going to use on the intaglio surface, air thin. I do not light cure at this point. I will light cure once I actually physically reline the material.
Okay, gotcha. And then you're adding Luxatemp, and are you doing any curing at all at that point?
I cure after the Luxatemp. So once the Luxatemp has been placed and I seat the jig, I will then go ahead and light cure at that point.
Got
Yes.
it. Got it. Okay. A few questions about gluma as
Hmm.
well, and about the whole desensitizing issue. So,
Hmm.
there's a question like, well, if as you said, you do a total etch, you etch the dent in as well,
Hmm.
and is that why you're using gluma, right? Because the etching of dentin would tend to
Yes.
make it more sensitive.
Yes. And but again, like I said previously, I use Gluma regardless for the desensitization, but also it does help increase bond strength. So you get
Got it.
double
Got it.
whammy with that.
Yeah, I was actually looking through the literature on that, and there's studies that show both ways, but specifically, gluma has been shown to increase bond strength.
Mm,
Not all of the hema and glutaraldehyde
mm,
desensitizing
mhm.
agents have been shown to do that.
Good to know.
And when you're bonding veneers, are you pumicing the teeth?
It depends. So if I have a situation where, like I discussed, if I have a little bit of bond that's left over, and I feel like I need to, or if there was during the try-in, I was getting some bleeding in that area, then yes. So sometimes I do, sometimes I don't. It
Okay.
really just does depend.
And we had a comment that no retraction cord when you bonded that case,
No, no retraction cord.
just because you were super gingival and tissue was in
Yes,
good
I try to
shape and
stay
all that
equal
stuff.
or super gingival if I can.
Okay, great, great. Um, this question about preps, but I think while we're in the neighborhood, do you always break contact when you're prepping veneers?
No, not always. If the restoration leads me there, or if the patient has like spacing that's existing, I will prep past where that contact point should be so that my finish line can be there. Um, I do know that the previous lecture I gave on veneer preps is online, so you can watch it there. I go a little more in depth, but the answer is it depends on the case, to be
Right,
honest.
and you certainly don't do it on your no prep veneers, right?
Right.
There you go. Okay. And then you mentioned now the attendee uses the term microprime, which is one of the products that you talked about at desensitizing. But
Mhm.
let's generalize it to all desensitizing. Do you use it on just regular composite type fillings? Anytime you're cementing a tooth? I mean, you said you used it all the time, do you?
I do. I use it all the time for every restoration that I do. Especially if I'm placing a liner or a base, I will go ahead and use the desensitizer first. Yes.
Okay, great, great. So, let's see. Got it. Uh, one of our attendees is concerned that curvicular fluids might be coming in and affecting the bond if you
Mm-hmm.
don't use any kind of cord at all. And I imagine that could
That's
be
the risk.
a
Fair.
concern. Very good.
Hmm.
All right, Dr. Brown, you've done it again. We appreciate it. And again, you can go back on and look at this recording when it's posted, and look at the video and get further details. But thank you. And Dr. Brown, you're going to be
Thank you.
teaching a course on this next year as well. So I think
I
that's going to
am.
be I don't know if I told you that before, but that's
You did.
but it's gonna be great. So Thank you, Dr. Brown. Thank
Thank you.
you to our panelists and all of you for attending. This is our fourth year doing this. It's been a really fun year. Thanks, everybody. Thanks especially to Mo and of course Nicole, who is the person that makes this all happen. We would all just be sitting here staring at our laptops if it wasn't for Nicole. And she makes sure we've got great speakers and a great program every week. So thanks to you for the amazing job you do. So we will see you all not next week, but we'll be back on January 3rd. And we will have a very special guest. We're going to have Dr. John Suzuki, who's really a pillar of dentistry in the United States. He is a highly respected periodontist as well as a microbiologist. He's part of the FDA's panel. He's a respected academician and researcher, and he's going to be bringing us up to date on the impact of osteoporosis as well as the medications that are used for treatment. So that's going to be a great lecture. We're going to be here for that in 2 weeks. I'm looking forward to it, and I'm looking forward to having a great holiday, and I hope all of you do as well. And we'll see you next year in 2 weeks. Take care. Bye-bye.